So we're going to talk a little bit about cannabis tonight. It's very opportune since we just had legalization yesterday. I don't have any conflicts of interest. I did have some shares in Orion Health, which is a pain clinic that I worked at, the U.S. division, that I sold for no profit, unfortunately, last year. That's about it. And I don't think there's much bias to mitigate. Aside from, I just wanted to say I do see all of this through the lens of an addiction medicine specialist. So I have practiced for over 22 years as an addiction medicine specialist. So some of my palliative care colleagues see this topic quite differently because what they've seen it through the palliative care lens. So just to know. It feels like the mic's getting some feedback. Is that, I don't know if that's normal. I don't know if this one's still on or what's going on. Anyway, our learning objective is going to communicate evidence behind the major health risks and potential health benefits of the product and review the College of Family Physicians guidance document on dried cannabis, including implications and contraindications. I think the larger issue, and today's a really good day to acknowledge that larger issue, is that big cannabis has really moved in, both the tobacco industry and the alcohol industry, to try to promote the sale, as well as just straight cannabis producers. Even the term medical marijuana was invented and propagated by multimillionaires and billionaires in the United States in order to try to change legislation in order to basically make profits. So they tried to compassionize and medicalize the face of their profit machine, potentially. So just to acknowledge that that's more of a concern than people using the odd joint on a weekend or people who are palliative using it. And I don't think many Canadians wanted people who had low-level possession to be arrested. So those really aren't the big issues. I just wanted to start by paralleling what's going on right now in cannabis with tobacco. Many of you may not have known that at one point when tobacco was first brought in from the Americas to Europe, that one of Columbus's crew, Senor Juarez, was walking down the street with smoke pouring out of his nose and mouth, and his neighbors ratted on him to the Spanish Inquisition, and he was questioned for about 6 years and tortured to try to get the demon out of him. And so the Pope then decreed that it would be illegal to possess, and all over Europe it became illegal to have tobacco. And if you were in Russia, you could have hot molten oil poured over, metal poured over your skin, or be banished to Siberia. So there was a criminalization of tobacco. Over time, some patients were reporting benefits to their doctors, where there was eventually a publication of health benefits of tobacco. And then it became medicalized. So tobacco you could only get in England on a prescription, and within a year doctors were absolutely flooded. So it was things like mawkishness and sottishness, depression, asthma, enema with tobacco curing constipation. I think that probably still works. And then within a year to 2 years of that happening, doctors were overwhelmed with the requests for medical grade tobacco. And so they then passed legislation to legalize it. And within 1 year of legalization of tobacco in England, there were more shops selling tobacco than there were tea shops and pubs. Just like within 1 year of legalization of cannabis in Colorado, there were more dispensaries for cannabis than there were Starbucks. So we'll start with a little bit of history on endocannabinoids. We do have endogenous cannabinoids that we make. The most famous of that is anandamide, named after the god of bliss, the Hindu god of bliss, Ananda. We do have CB1 and CB2 receptors that these anandamides bind to. So whenever you take something from the outside, an exogenous product, you're going to change your own endogenous anandamide system, your endogenous cannabinoid system. And we have anandamides so that we will bond to each other. They're highest at the time of birth and when we're breastfeeding, so we'll bond to our moms and to our parents and to our clan. And so when teenagers smoke up after school among each other, I well, anyway, we're being filmed. Maybe I won't say what I was going to say. Anyway, you know, they are really bonding with each other quite a bit, and other people outside that ring can seem less interesting and less close. So it just so happens that cannabis sativa makes a substance that binds to these receptors. There's over 2,000 strains of cannabis, and there's over 400 chemicals. There's now, you know, over 70. I heard the other just this week that they've now identified over 100 cannabinoids. So that's one of the problems with the research, is that since there's so many cannabinoids and so many strains, then how do you compare one study to another when they may be using all different strains? And what we usually just hear in the study is how much THC is in the strain that's used, rarely the CBD, plus all the other cannabinoids and terpenes and things. So we often don't know what we're actually comparing. Also, most of the systematic reviews bunch together smoked cannabis, edible products, prescribed cannabinoids, all of that into the meta-analysis. So again, you could have washout of effect, both positive and negative, for side effects and for positive effects. So just to know that before we launch in on what it is we think we might know about this product. The first thing I just want to mention is that delta-9 THC is the main psychoactive component. So this is the thing that causes, that is addictive, causes dopamine release in the nucleus accumbens. It's the product that will cause the psychosis. It can cause paranoia, anxiety, and it's the thing that will produce a withdrawal syndrome in about 1/4 of people who use it. And that was based on about 9% THC. Now that THC is higher, the rate of addiction is higher with product. It's dose dependent to THC. And we can see that the potency of THC has really been rising over the years. This graph stops in the year, oh, they got cut off there, but that stops in about 2012 or 2014. And the amount of THC now in product, when I was in high school, it's about 2 to 3%. So now in BC bud is around 20-25% average. And there are some hybridized strains that are up to 45%. And then I'll show you some other products that are derivative products that we'll see are much, much higher. There's lots of different cannabinoids. As you can see on the screen here, most of these claims is from low-level evidence, animal research and things. And as we know, about 1 in 20 animal research studies actually pan out in humans. But a lot of the stuff that's being advertised in the dispensaries is stuff that either is a claim or anecdotal report, or it's animal research. And as we know, we can't make a claim that it's, you know, validated in humans until you do phase 3 trials. So I'm just going to talk about one other cannabinoid, so that's CBD, which you may have heard a fair bit about. So that's cannabidiol. It's not psychoactive that we know of, and it may actually be protective against psychosis. So when the plant made about 2 to 3% THC and 2 to 3% CBD, it could protect against that psychotic tendency of the THC. But as THC rises, the plant has trouble making CBD. So usually CBD goes down as THC goes up, unless you have a wildly hybridized strain. So with cannabis sativa, you get high THC, low CBD usually, whereas indica strains are the opposite, high CBD, low THC. Unfortunately, in the dispensaries we have around British Columbia, there's no quality control on THC and CBD. If it's a licensed producer, they're supposed to have someone who tests in-house lab, and Health Canada is supposed to monitor that. There's been some controversy about how accurate that is, and if the even the licensed producers are being able to keep up with quality control. There was an expose in the Globe and Mail about that. I did, with our fellows at St. Paul's Hospital in the Addiction Medicine Fellowship, we did ask, or actually in the Family Medicine Residency Program, we asked Health Canada for the data, because it should be public access, and they declined. So it just led me to think that perhaps they're not as accurately labeled, even in the licensed dispensaries. So here's an example. On the left is a cannabis sativa strain, and you can see that it's over 21% THC with virtually no CBD, and on the right is an indica strain with over 16% CBD and no THC, virtually. So I usually tell my patients to try to switch from a more THC heavy, if they're recreationally smoking for safety, over to an indica strain. If they're trying to use it for more medical purposes, because that may be the anti-inflammatory. Some of my patients tell me it feels like a body stone to have the indica strain and a head stone to have the sativa strain. But if someone is seeking it for recreational pleasure, they're going to use a sativa strain and they're going to crank the THC as high as they possibly can usually. So what does that look like? So I'm going to click on a few of these and we have some examples. So the THC, again, can be anywhere from 0 to 30, and they can just look like little buds here, okay? And then cannabis oil. So the oil can be made from, there's resin from the buds and leaves you can make hash from. That's just a straight resin. You can take oil and make hash oil from that, and mix it down. You can extract using another kind of oil, like olive oil, and boil it down, or a butter. Or you can further boil, and again, some of my patients put it in an actual butter and boil it down and then scrape out the leaf product, and then you can use that then to bake with. And then if you keep boiling down and you extract with a volatile solvent, like butane, you can get waxes and shatter. So this is an example of shatter. Wax is just stickier. It looks sort of like the butter can crumble. It's thick and sticky. Shatter looks like peanut brittle in a way. It's like, or glass, and it breaks like glass. And so that's 85 to 95% THC. So I think when they were looking at cannabis legalization, many of the people in the legal profession were thinking about the cannabis they might have smoked in high school. But what we have now are products that, potency-wise, is the difference between chewing on a cocoa leaf and doing crack cocaine, is the difference between smoking cannabis at 2 to 3% THC and smoking shatter. And unfortunately, when we write prescriptions for medical cannabis, we can control the amount of grams the patient has, but the licensed producers does not have to honor the percent THC that we write on the prescription by law. So we have no control over the THC and CBD content, and that's why it's not really a medication as such, because we cannot control it. It'd be like saying, I think you need an opioid, and I'm going to send you to the pharmacy, and you and the pharmacist kind of work out what strength of oxycodone you're going to have. I can tell you how many pills you get, but you get to talk to the pharmacist about what strength that pill is. It might be a 40 milligram or a 5 milligram. And who is advising our patients are the people who are selling. The other issue that we have, that I just had a patient this week talk to me about this once again. I've had many patients tell me this. But if you write down something like 25 grams a day, they can have 5 plants per gram. That's 125 plants. They can be my height, with buds the size of my head, and with the lighting nowadays, the operative lighting that is LED lighting that goes day and night, they can force 7 flowerings a year. So I heard Mark Weir speak recently, and he said that a prescription like that on the street, the yield from that will be $350,000 a year. So you can see, if you have malintent or positive financial intent, depending on how you look at it, getting a prescription for a medical grade cannabis is highly, highly, highly lucrative. And that's one of the reasons people can be a little more agitated when they talk to you about it. So it's a lot more than I make a year, just with one prescription. Hemp itself is a cannabis indica, and it has virtually no THC in it. So if your clients are really interested in having a cannabis product that they don't get for sure will never get psychotic from, then they can try hemp oil. The thing is, with all cannabis products, if you heat them, you convert from THC-A to THC-B and CBD-A to CBD-B, so you make it more active. Or CBD itself, if you leave it for a long time, or it will slowly convert, as well as THC can convert to the more active form. If it's just like, sort of like wine fermenting, you know? Okay. I wanted to talk to you a bit about edibles because there was a really good study by Vandry published in JAMA in 2015. They sent a researcher up the coast from California, Oregon, and Washington, going into dispensaries, legal dispensaries, and buying product, and then they take it and run it through a mass spectrometer to see actually how accurately labeled are edibles for THC and CBD. And they allowed a 20% range, 10% below and 10% above. So we'd never allow that in the pharmaceutical industry, right? We'd want a tight range on medication, like 1 or 2%. So they were really liberal, 20% range, and this is what they found. They tested 75 products randomly selected, 47 different brands, LA, San Francisco, and Seattle. THC was accurately labeled in just 17% of product, 60% were overlabeled, 23% underlabeled. 44 products had detectable CBD on testing, only 13 were labeled. CBD was accurately labeled in 0. 4 products overlabeled, 6 products underlabeled. The mean THC to CBD ratio was 30:1, and only 1 had a 1:1 ratio. There's some evidence that the best ratio is 1:1 or more CBD than THC. None of the products have more CBD than THC. So buyer beware is what you need to tell your patients. They will not, especially with edibles, you cannot be certain of what you get. Supposedly, the licensed producers in Canada will have more accurately labeled because they're supposed to be spot tested by Health Canada, and they're supposed to have an in-house chemist. So I can't comment because we haven't seen the data, but as I said, there was an expose that revealed that even they aren't as accurate as one would hope. So we need to explain to our patients that it's quite unreliable and to be very cautious. I had a patient the other day who was like, I'm taking a pure CBD product, I buy it, it's all medical grade, blah, blah, blah. I said, okay, let's do urine drug screening. Just for fun, let's see what's in your urine. And sure enough, THC lights up like crazy. So she was shocked. Now, how much THC? Is it enough to make her mentally impaired or not? We don't know. So just to know that she would not pass a test. If she had safety-sensitive work or gotten in an accident and they P-tested her, she can't just say, well, I was only on CBD. We don't know how much THC is in her system. So what are the cannabinoids that are available through prescription that you can actually write a real prescription for? And that's Nabilone or Sesamet. It's a synthetic delta-9 THC. And I put some dosing on the screen for you there. To note, this product does not show up in a urine drug test. So you can prescribe this, and if they use cannabis on top of it, you can tell by urine drug testing. So that's one of the things that doctors sometimes like. The downside is, in the United States at least, there is a black market for this because people they can get quite high with it, but they won't test positive at work. Nabiximols, which is Sativex, buccal spray, it's a balance of natural CBD and THC. It will show up on a urine drug screen. It's a spray you do inside your mouth. It can be a bit labor intensive. You can need up to 12 sprays a day and stuff like that depending on how you divide it. It is approved in Canada and the UK for advanced cancer pain, MS-associated pain, spasticity, and this is the product that we do recommend, if people can afford it, that you would try before you would try smoked cannabis or recommend an edible. And if not, then Nabilone. The advantage of Nabiximols is you have that balance of THC and CBD, so it may be less psychotic producing and less anxiety provoking, potentially, but there's no good research on it. Dronabinol is no longer available in Canada just because the market share was too low, so they scurried back to the United States. Ingested marijuana is about a third more than smoked in terms of you need about a third more to get the same effect. So not 4 times more or 8 times more, which is what patients try to convince you. Like, I'm making butter, so I need 25 grams of cannabis. You know, 1 joint is half a gram. So if you write a prescription for 10 grams, let's say, that's 20 joints a day you're saying your patient can smoke. Like, if you really think your patient needs that for pain control, the studies on pain show that people need about a quarter to a half a gram. So that's like half to 1 joint for pain control. Beyond that, it's just intoxication. Even at that level, it can be intoxication if you have a high, that's at 9% THC. Right? So this is a very complicated equation to try to explain to your patients. And patients use a huge range of smoked marijuana. Some of the pharmacokinetics, if you inhale, the peak is within 10 to 30 minutes, the duration is 2 to 3 hours, but if you ingest, it's 1 to 2 hours, the duration is 4 to 6 hours. First pass hepatic metabolism. The problem here is that what happens is people are used to smoked, that they get, within 10 minutes they know how high they are. And so then they take an edible, and an hour later they're still not feeling anything. So they'll take another, and another, and another. And then 3 hours later, all this adds up, and then they go, and they're vomiting and anxious and paranoid. So that's when there's been increase of emergent admissions. And the highest THC is found not only in fat, which a lot of people know about, but also in heart. So, and there's cardiac effects. So we need to really warn our patients. I'll go through that in a minute. It's metabolized to the cytochrome P450. Half-life is 2 to 60 hours. Excretion is 1/3 in the urine, 2/3 fecal, and the urine drug screen is positive for about 5 to 7 days if it's a one-time use or like weekly use or every couple week use. If you're a chronic daily user, it can stay in your system for 45 days or more. So if someone said, oh, I only used once 2 months ago, but it's still in my system, that's not an accurate statement. So Nora Volkov, who's the head of NIDA, the National Institute of Drug Abuse, and an excellent researcher, reviewed the literature in 2014 to see what are the short and long-term adverse health effects of cannabis. And she showed that impaired memory, making it difficult to learn, impaired motor coordination, an increased risk of injury, impaired driving, doubling the motor vehicle accident rate if you drive after use, and that increases synergistically with co-exposure with alcohol. Altered judgment, increased risk of sexually transmitted diseases because you're impaired, acute drug-related paranoia and psychosis, which is dose-related and in part based on genetic susceptibility. So the higher the THC, the more likely it is that you can get psychotic. Long-term addiction is about 9% of experimenters. That's when THC was about 3 to 5%. So it's higher now. 25 to 50% of daily users meet criteria for a cannabis use disorder. It can alter brain development in the hippocampus and prefrontal cortex. You can get poor educational outcomes and cognitive impairment, decreased IQ by 6 to 9 points in frequent users. This is non-reversible if they start in adolescence and are daily frequent, heavy users. If they're infrequent users, it doesn't seem to impair. It's reversible with a 4-week washout if you're an adult. When you start, it diminished life satisfaction and achievement, this amotivational syndrome that's quite classic, and chronic bronchitis, possibly COPD, and increased risk of pneumonia. Now COPD has been confirmed by the National Academy of Science, Engineering, and Medicine. Increased risk of psychotic disorders, including schizophrenia. So we used to think it was only in people predisposed to schizophrenia, but now we know you can actually, you have a high risk of having a psychotic break and becoming schizophrenic in your life if you use cannabis, even if you don't have a family history. Again, dose dependent on how strong the THC is. Anxiety and depression. In Nora Volkov's study, it was not causally related, but in the later studies, which I'll show you, they've now confirmed that anxiety and possibly depression can be causally related to the THC dose. CBD might be protective against anxiety, but we don't have enough studies yet. So it can be anxiolytic, whereas THC is angiogenic. Do any of you have experience among your patients or friends or anything with that, getting really anxious with THC? Yeah. So some people really, especially if people are cannabis naive, they weren't long-term smokers, they often don't like the effect. So the National Academy of Science, Engineering, and Medicine published in 2017 an updated, very detailed systematic review. And everything that they published supported Dr. Volkov's conclusions. In addition, a positive association with early initiation, cannabis use disorder, and other substance use disorders, showing that marijuana actually is a gateway drug. There has been a lot of controversy about that in the past. Also, with this positive association for schizophrenia, testicular cancer, prediabetes, COPD, overdose in pediatrics, mainly from edibles, gummy bears and the like, low birth weight neonates, bipolar disorder, increasing the risk, anxiety disorders, and suicide completion it's associated with, not increased risk of suicidality, but completing suicide, increased severity of PTSD. So this is the opposite of what most people think. People think they're using cannabis to treat their PTSD. They get into a withdrawal cycle then, and then they use, just like when people are drinking alcohol, hey, how they can have a withdrawal syndrome that they treat the next day with drinking alcohol, the same can happen with cannabis. So CBD may be anxiolytic and might be helpful for PTSD. There's a large trial going on with the VA in the United States right now using pure CBD oil. So we don't, that results isn't in yet, so we can't say yet, but that's a possibility. And there's an increased risk of arrhythmia, myocardial infarction, and stroke with THC products. Most people in the public don't know that. So people who have arrhythmias, cardiovascular disease, any heart attack or stroke shouldn't be using these products. Is CBD protective? We don't know. Could CBD be part of the problem? We don't know. So we just usually say to stay off cannabinoids. No association with lung, head, or neck cancer that can be found right now, and no association with asthma, just COPD. Ineffective, so the evidence is quite clear. It does not help dementia. But again, if CBD only products are used, we don't know, but for sure, products with THC at least do not help dementia. They don't reduce intraocular pressure and treat glaucoma. In fact, you get rebound hypertension of the globe, so this is not a good treatment for glaucoma. And it's not a treatment for depression in pain patients. So that's been ruled out. So stroke, the endocannabinoid system modulates cerebral blood flow. Numerous reports link cannabis use to hemorrhagic and thrombotic stroke, TIA, and reversible cerebral vasoconstriction syndrome. And young adults, cannabis use is associated with a 17% increased risk of hospitalization due to ischemic stroke. I was just at the World Congress of Neurology. I went and presented there some of my other opioid research last year in Kyoto, and they showed studies like this, where 14-year-olds are stroking from high-dose cannabis use with no other risk factors, so multiple cerebral infarctions in this case. And they've ruled out all clotting causes, all genetic causes, all infectious causes. And there's numerous case reports coming up of this worldwide, and it's that whole thing of, and in animal models, it's vasoconstricted. So you can see it constrict and you can have ischemic stroke in animal brain models. So we think that this is true as well in human models. So we've unleashed this on the public. Yeah. And then the latest systematic review, this is an old systematic review that just shows, at least when it's illegal, that it's when cannabis was illegal, it was associated with diversion, cocaine in the urine drug screen, prescription forgery, and no opiates in the urine drug screen among people who were prescribed opioids. So a 6-time increased risk of these kind of aberrant behaviors compared to people not using cannabis who are on opioids. So just to remember that all mood-altering substances, be it cocaine, alcohol, cannabis, can all relieve pain while you're intoxicated. So if I do a light Coke, my pain's going to go down. If I chug a 26er, my pain's going to go down. So while you're impaired, you will not feel pain. But that's not a good way to manage pain. So what you have to see is if you are going to prescribe or suggest that someone use it, you have to make sure that they're more functional and not just pain dissociated during impairment. So that's a really important distinction. So, and anything that causes dopamine release in the mesolimbic system can be overvalued by the patient, even in the absence of a true addiction. Hence the emotional attachment around discussing opioids, cannabinoids, and benzos with patients. I usually don't get an argument if I say, I don't think your ibuprofen's working, I'm going to switch you to naproxen. Like they're like, or let's try pregabalin. They're like, whatever. But, I don't think your cannabis is working or your opioid is working, let's switch that. And there's this immediate argument and attachment, even if the person told you just now that it really wasn't working very well. And that's because the brain will overvalue anything that releases dopamine. That's how we're wired. It moves up in salience hierarchy. So food that you're eating, loved ones, your kids, you will protect those. And in the same way, since that same area of the brain is stimulated, you will protect anything that releases dopamine. So you'll be overly protective of a cannabinoid or an opioid or a benzo or a stimulant. Anybody experience that in the office? People being a little more overly protective of those substances? Yeah. Compared to, like, I'm going to change your antihypertensive. No one ever argues with the doctor's opinion on that. And this is why. So if you can see that, then you don't get so triggered when they're fighting with you over this. Because you can see, wow, that's your reptilian brain speaking to me right now. And you were protecting what you think is a food source, but really that's something that might give you an overdose and kill you, you know? So it's this kind of thing. So if you can take a step back, that can be helpful. So again, addiction is about 9% of users, a lot less than some of the other substances, but that was when THC content was about 9%. And just to remind you that the source, this is a study out of Michigan, the source of grade 12 students' marijuana, that about 35% of them get it from somebody who has a medical marijuana prescription. So medical marijuana is highly diverted in our culture. Now that we're legalized across Canada, I doubt that it will be so much. So what are our implications in Canada? The Canadian Tobacco, Alcohol and Drug Survey, 15 to 24% in the past year have used cannabis, and ages 24 to 64, about 8%. The Canadian Community Health Survey back in 2012 was 1.3% of age 15 or over met cannabis use or dependence criteria. And the alcohol drug crash problem in Canada back in 2012, we'll see how it changes over time. The National Study of Fatally Injured Drivers in Canada reported that among the 363 individuals tested for fatal crashes, 45.5% tested positive for cannabis. So you can see that's a lot more people test positive who are fatally injured than the background use rate in the population. So that's concerning. It's not causative necessarily, but it's concerning. And we do know about impairment. Okay, let's try these clips. Let's see if I can do this. This is a minute and 15 seconds I'm going to show you.
A relatively new drug is hitting Ontario streets. It's called Shatter, and it gives users a much more powerful high.
I can't see my mouth.
It is a derivative of marijuana, and as Michelle Chung explains, the process to make it...
I'm going to drag this forward to 1 minute.
But in recent months, local police
Can you hear?
departments have started to confiscate small quantities of shadow.
We have had arrests, and our clandestine lab section has seen production of this.
According to the RCMP, the drug is extracted by filtering marijuana with a solvent like butane through a tube or pipe. That process can fill a room with volatile vapors, and that concerns police.
We were using chemicals, and these chemicals are explosive. So it really takes the smallest of spark, even static discharge sometimes, that can set off an explosion.
There were 32 hash oil explosions in Colorado last year. No one's been killed, but more than a dozen were hospitalized. 11 people in Barrie were admitted to hospital over the weekend, some with severe burns because of a house explosion. Police suggested the cause may have been something similar to the process of making shatter.
We suspect that the explosion was due to butane canisters exploding within the garage while marijuana resin was being extracted.
Barrie police today won't say whether someone was making shatter in that house.
Okay, so there's that. Just hang on. So that's just to give you a feel for some of the hazards of that people are making. And then oh, hang on.
This week on Marketplace, are we ready for this trip? Kenny's up first. All set to go? Good. When he lights up, what changes are going on inside his brain?
Can you guys hear okay?
While our testers get high, I have an appointment at a local Denver hospital. Toxicologist and ER Dr. Ken Hurd has seen a big change since weed became legal 4 years ago.
Prior to legalization, we really didn't see marijuana-related complaints at all. But in our emergency department, we're seeing people on a daily basis.
What effect do you see just in this ER?
Severe abdominal pain, nausea, vomiting, and often shocked to find out when we tell them that the most likely cause of this is because you're using marijuana.
And that's not all.
There certainly is some fairly good scientific evidence that links marijuana use to some mental health disorders, including anxiety.
That's been an ongoing worry for Audrey when she smokes pot.
Sometimes I get panic attacks where, like, I literally think that I'm dying. I feel like I can't breathe.
You're feeling a buzz. You guys need some music in here?
London's Schulich School of Medicine.
So this is the main lab where we do most of our physiological work.
Top Canadian neuroscientist Stephen Laviolette researches marijuana's effects on the brain, and he's discovered a troubling trend.
If you're exposed to high levels, especially of THC, you can experience the sort of temporary symptoms associated with schizophrenia, sort of cognitive impairments, paranoia.
Schizophrenia.
Yes.
Does he also see that in the brain patterns of our dead smokers?
Based on the brainwave activity, this individual is showing the source of disturbances in gamma activity that might be reflective of what we see in schizophrenia.
So they took normal volunteers and
This
smoked
person
them up?
has schizophrenia? No, definitely not. So schizophrenia is a long-term sort of chronic disease. They're not having a long-term, lifelong disability, but they can certainly experience psychotic-like episodes that might last for a couple hours.
Laviolette sees schizophrenia-like patterns in all the participants' brain waves after smoking, not just Audrey's, who experienced that panic attack. Because they're all adults, their brain waves will return to normal. But for teenagers,
the adolescent brain is most vulnerable. So the adolescent brain is going through a period of all sorts of changes, all sorts of important molecular changes, structural changes.
would you tell a young person under 25 with a developing brain to not smoke, to not use weed at all?
Yes, I would. It's simply not worth the risk.
Not worth the risk? Well, that's a problem in Canada, where young people already smoke more weed than any other teens in the developed world. So we're putting weed to the test.
The higher that THC, the more addictive.
Yeah. Okay, let's see. Was that useful? Yeah, okay. Let's carry on then. And so is it all doom and gloom and reefer madness and everything's bad now? So hopefully we'll give a little bit of, that's the downside, everything I've been talking about, so we'll give a bit of a balanced approach. So there is some analgesia effect. Possible mechanisms of that is THC binding to CB1 and CB2 receptors, causing activation of attenuation of nociceptive response. Also, amygdala activation can contribute to the dissociative effect, and so people can feel pain but not care about it. And most of my patients tell me that they still can feel the pain, but they just don't care as much about it. So it's more of a dissociative effect. Other potential medical uses that this National Academy for Science, Engineering, and Medicine, that there's substantive evidence, not a big treatment effect, but a lot of evidence that points in this direction, that decreasing chronic pain in adults, a low effect size, which we'll talk about in a minute, and an antiemetic for chemotherapy-induced nausea and vomiting, and MS spasticity, largely self-report, but some studies on that. There's moderate evidence for possible improvement in short-term sleep for chronic non-cancer patients, fibromyalgia patients, and MS patients, not general patients and not for general pain patients, but in this category, is at least what the evidence is. It's unclear if it's an intoxication effect just before bed, and TCAs do show more improvement in the study that Mark Weir showed that was published in CMAJ years ago. After 3 weeks, which is how long it takes for TCAs to kick in, the TCA effect was more prominent than a cannabis effect for sleep. Limited evidence or poor quality evidence on increasing appetite, lowering anxiety. There's one study showing it could lower anxiety for public speaking if you had a social anxiety disorder. It was just a few people, very small study. So that's, and yet everywhere you go, that's what's advertised, use it for anxiety. Decreased inflammatory cytokines, mainly with CBD products, and mitigation of Tourette's, largely self-report again. There's some evidence in animal models that THC may actually induce epilepsy, epileptic seizure in seizure-prone rats, but CBD may be protective. And the U.S. Food and Drug Administration has just authorized for the first time a pure CBD product for Tourette's, one of the types of childhood epilepsy, if you're unresponsive to regular medication. So there's 2 kinds of childhood epilepsy that have now been authorized. I'm sure that pure CBD product is going to be used for all sorts of things. I believe that it's either now or soon to be authorized also for MS spasticity, but it's our purest product. We don't have it available in Canada. So if we look at a systematic review of systematic reviews of medical cannabis that was just published this year by Dr. Allen in Canadian Family Physician, the conclusion of that was that there's reasonable evidence that cannabinoids improve nausea and vomiting after chemotherapy. They might improve spasticity, primarily in multiple sclerosis. There's some uncertainty about whether cannabinoids improve pain, but if they do, it's neuropathic pain, so not just generalized myofascial pain. And the benefit is likely small. In the studies, usually it's about a 0.5 point on a 10-point scale, which is what acetaminophen is. So that's the kind of level you're looking at. Beyond that, it's often dissociation. However, there aren't studies of things like shatter, like our patients are using. Maybe that helps pain a lot more, who knows? It's just, can you function on it? Adverse effects are very common, meaning benefit would need to be considerable to warrant trials of therapy. If we look at cannabinoid for medical use, this was the study in JAMA. Most studies don't look at what is the, how much benefit is there, but this one in JAMA really parceled out, and as I said, it's about a 0.5 point on a 10-point scale. Again, we only have 6 trials that bothered to really scale this. Moderate quality evidence to support the use of cannabinoids for the treatment of chronic pain and spasticity, but the effect size is small. Effective cannabis use in a population in people with chronic non-cancer pain prescribed opioids. This is findings from a 4-year prospective cohort trial done in Australia. This is the largest cannabinoid study ever done, published this summer. They took people who were prescribed opioids for chronic non-cancer pain, and they followed them for 4 years, and they looked at people who used cannabis during that time and did not use cannabis during that time. And they were hoping that it would be opiate sparing, that people had better pain, that people could come down or off their opioid, that they had better function. That's what all the claim is about, and that was the hope. But what the trial found was that cannabis was very common in people with chronic non-cancer pain who'd been prescribed opioids. They found no evidence that cannabis use improved patient outcomes. People who used cannabis had greater pain and lower self-efficacy in managing their pain. So it's the opposite of what they were hoping for. And there was no evidence that cannabis use reduced pain severity or pain interference or exerted an opiate-sparing effect. People didn't use less opioids because they were using cannabis, which is the opposite of what people hoped. There were some studies that linked out in the U.S. that looked at states that legalized cannabis having a lower opiate overdose. So they were trying to say these are associated. However, in those same states, those were states that had really ramped up their doctor prescribing interventions. So if you look at correlation, it's just as equally correlated with doctors learning to prescribe opiates better, and their overdose rates come down. So you have to be careful how to interpret this kind of data. As cannabis use for medical purposes increases globally, it's important that large, well-designed clinical trials, which include people with complex comorbidities, are conducted to determine the efficacy of cannabis use for chronic non-cancer pain. Now, this wasn't a randomized controlled trial, so they didn't give cannabis to people who are already on opiates and see how they did. This was an observational trial, but it's the best study we have so far and the largest study. Most cannabis trials are 25 to 50 people, and they studied them for 2 to 8 weeks. So studying people for 4 years in a natural setting, how people actually use cannabis, this was the best trial we have so far, and unfortunately it has not been very promising. On the other hand, we know that the relative risk from death using opioids is about 14 compared to baseline, and cannabis is 1, so there's not an increased risk of death unless you consider motor vehicle accidents or people getting psychotic and hurting themselves or committing suicide. So if you just look at overdose, you virtually can't overdose by using cannabis. You can get really psychotic, but you can't usually overdose. So it's safer in that way. So again, with any medication, there are risks and benefits, and you have to weigh harms and benefits. And you'll have to do that for your own patients. So the access to cannabis for medical purpose regulation is still in place despite legalization. So you would get, the patient would request a document from a doctor or an NP, and the document specifies, it's not a prescription, it's a document, it specifies the patient directions for use, the amount to be dispensed per month up to a year at a time. Now, we don't usually give a year prescription for opioids or any other addictive substance at a time, so that's ill-advised. Patient receives dried cannabis or cannabis oil in the mail from a licensed producer, tested for THC and CBD content, pests, fungus, chemicals, etc. Or the patient or their designate can grow up to 5 indoor plants or 2 outdoor plants per gram and make oil. So it's only the old legislation that people could grow 25 plants per gram. Now it's 5 plants per gram. But there's lots of people who got grandfathered in to the 25, and there was a legal challenge in the federal court, and they were granted, so they could still have 25 plants per gram. So, anyway. Or sorry, they can go up to 25 grams, 5 plants each. Now the limit is lower. So it's not on Pharmanet. So unlike other medications, your pharmacist isn't going to be able to say to somebody, you know, there's this drug interaction or health interaction with something you have. And we can't see on Pharmanet whether a patient's on this or not when we prescribe other drugs. There's not been a lot of studies on drug-drug interactions, so we're going into a whole new world. Illegal storefronts and dispensaries abound in BC without quality control, and yet lots of claims. There's the dried cannabis guidance document from the College of Family Physicians of Canada. And dried cannabis differs from prescribed products in that Health Canada has not approved it for therapeutic use. The CMA and the CMPA does not endorse its use, so if you prescribe or write out a document and someone has a psychotic reaction and their family sue you, you're on your own pretty well. The CMPA is not going to back you. Authorization for dried cannabis. Okay, so these are the recommendations. It's an older document. There are some newer documents, but I think this is I like how it's laid out, so I'll just go through this. Authorization for dried cannabis should only be considered for patients with neuropathic pain that has failed to respond from standard treatment. If considering dried cannabis for treating neuropathic pain, the physician should first consider adequate trials of other pharmacological and non-pharmacological therapies and an adequate trial of pharmaceutical-grade cannabinoids like we went over earlier. The next recommendation is that it's not appropriate for the treatment of anxiety or generalized insomnia, maybe insomnia in pain or fibromyalgia patients. Dried cannabis is not appropriate for the following patients. So these are contraindications. If they're under 25, if they have a personal or strong family history of psychosis, if they have a current or past cannabis use disorder, if they have an active substance use disorder, if they have cardiovascular disease, if they have respiratory disease, or they're pregnant or planning to become pregnant or breastfeeding. So the cardiovascular disease, there was a great study that would never pass ethics now that was done in the 80s where they took patients with angina, ran them on a treadmill for a burst protocol, saw when they got flipped T's, and then smoked them up and ran them on the treadmill again. And they found their time to angina and to altered ECG was vastly shortened if they just had cannabis. So think of all the patients with cardiovascular disease in the country and who are going to want to experiment with this substance now. So anyway, if it...
Any different than if they just smoked a cigarette or a cigar?
Oh, I don't know, I don't remember that from the study. But cannabis usually isn't as constrictive. I don't know. Good question though. Is smoking anything combustible, irritating your lungs? I don't know. But we do know that it's vasoconstrictive in the heart and the brain. So anyway, and also to authorize with caution. So this is like yellow flag. The other were red flags. This is yellow flag. If you have a concurrent active mood or anxiety disorder, if you smoke tobacco because it's synergistic, the COPD effect on the lungs of tobacco. So it's called a blunt when you smoke tobacco that's mixed with cannabis. If you have risk factors for cardiovascular disease, or if you're a heavy alcohol user or taking opioids or benzodiazepines in high doses, or are on other sedative medication. Physicians should follow the regulations of their province, obviously, and monitor their patients for therapy to see if there's benefit and if they're abusing or misusing the medicine. Before signing the medical document for dried cannabis for pain, conduct a pain assessment. Assess the patient for anxiety and mood disorders and for substance use disorders. So the doc in the box, where the patient walks into a cannabis dispensary and a doctor Skypes in and asks them what their condition is, and the patient tells them and the doctor authorizes and gets a kickback from the dispensary, plus gets to bill MSP for telemedicine, I think is an unethical practice, personally. The physician should regularly monitor the patient's response to treatment with dried cannabis, considering the patient's function and quality of life, in addition to pain relief, and the physician should discontinue authorization if the therapy is not clearly effective or it's causing potential harm. Patients taking dried cannabis should be, these are the old guidelines, advised not to drive for at least 4 hours after inhalation, 6 hours after oral ingestion, and 8 hours after inhalation or oral ingestion if the patient experiences euphoria. The Association for Occupational Environmental Medicine, which we're going to hear a lot about in a little bit from Dr. Ells, just one little point here is they recommend to wait 24 hours post-cannabis use to partake in safety-sensitive work, and for safety-critical work like pilots, the aviation department, yeah, perfect, recommend at least 10 days, and Air Canada has banned all use among its pilots because you can't, if they test positive, you can't tell how many days since they used, because we know that for weeks there is still psychological and psychiatric effects that wash out over time. So if you're going to authorize a patient on a document, you better ask if they have safety sensitive or safety critical work, because you can't write with good ethics something that they're going to take every day if they have to wait 24 hours to wash out, or if they have to wait 28 days to wash out, if they're safety critical. You know, they're a conductor on a train or they fly a plane. I mean, ideally the public wouldn't smoke for 24 hours before driving as well, but you know, we have people already on the roads. When authorizing dried cannabis therapy for a patient, the physician should advise the patient of harm reduction strategies, so to use a vaporizer instead of a joint or a pipe, much lower levels of carbon monoxide, and not to mix with tobacco. Caution when you're mixing with alcohol, opioids, and other drugs, preferably don't do it. Don't breath hold, I think that's a big joke. I don't know who doesn't breath hold, and caution when you take edibles, because it can build up later and it's really hard to control the potency. The physician should manage disagreements with patients about decisions around authorization, dosing, or other issues with unambiguous evidence-based statements. The physician who is authorizing cannabis for a particular clinical indication must be primarily responsible for managing the care of that condition and follow-up. So the doc-in-the-box scenario that we just talked about, that person, they're not examining the patient, following them for their pain condition, trying other medications, so that's not on. You should be following for that condition. It's essential that the authorizing physician, if not the patient's most responsible healthcare provider, communicate regularly with the family physician providing ongoing comprehensive care. And given the weak evidence for benefit and the known risk of using cannabis, the only sensible advice for physicians involved with authorizing cannabis is the maximum start low and go slow. So this is a standard joint nowadays, so it's half a gram. When I was in high school, it would be thinner, about half this size, about a quarter of a gram, but now they're about cigarette size. It's not this. But if the patient's doing shatter, that's basically what they're doing. but in small form, and they don't understand the potency. So they need to be doing something that's only this big in a little pipe, so it looks little, but this is what they're actually sucking on. Although it's not required, physicians should specify the percent of THC on all medical documents authorizing cannabis, just as they would specify dose when prescribing any other analgesic. And this hopefully will train the community, although because the lawyers were involved in creating all this, so they didn't set it up this way, so we don't have as much power. Dried cannabis, 1 to 2 puffs, Q5 to 6H, PRN, 5 milligrams or half a gram maximum per day, 9% THC maximum with high CBD for 30 days, dispense 15 grams. That would be like a month's prescription. Studies show relief 400 to 700 milligrams, so less than a gram a day is where pain relief usually lies, so it's about 1 joint. Case reports, some very tolerant patients, 1 gram and rarely up to 3 grams, and there's no need to prescribe 3 grams or more per day. Unfortunately, producers and dispensaries do not honor that 9% THC and high CBD direction, so patients get what they want. Their producer convinces them of. Still, it's important to list the dose. The other issue that's going on that many of my patients have told me about is that they will be approached by a producer. The producer will say, if you can get a prescription from your family doctor for the maximum amount that you're allowed, I will give you a gram a day for free, so you don't have to buy it, and I get to keep the rest of the prescription and sell it out the back door. So that's why that prescription that could be worth $350,000, or if it's a fifth of that, then at least $50,000 for 1 prescription. That's worth doctor shopping a little bit for. Some places give financial kickback, but some it's just you get your free weed instead of having to pay for it, just a gram a day, and then they have license to make all this if they're ever inspected, and they're selling it out the back door. Dr. Tobin of the University of Washington specifies low THC, high CBD as additional instruction, and if the patient is on an opiate, he or she must agree to taper by 50% if he's going to prescribe. Monitoring, you don't want to send out to another MD unless they're really reputable, and see the patient weekly to bi-weekly until the dose is established, then monthly, 3 month, every 1 to 3 months, and then include the an agreement like you would for opioids, and urine drug screen randomly and do callbacks. I urine drug screened a fellow who had an authorization under the old system for 25 grams a day, so that would be 50 joints a day. He should be smoking. And his urine test was negative for THC. So what does that mean? Yes, he's selling, obviously. So I said to him, well, it's very lucrative, isn't it, the sale of cannabis these days? And he said, oh, it's extremely lucrative. And you know what, doctor? I like sitting at home and cleaning my guns and thinking of people who piss me off. Yeah. So, and you just have to say, obviously you get your way through intimidation, and I'm not intimidated by you, but I have no way to remove your cannabis. Unlike I could call, if it was a prescription for an opioid, I could call the pharmacy and hold his dose, go on Pharmanet and put an alert. I have no way to do that. So there's no way for me to intervene. This man is making tremendous money, and there's no way to intervene. And if you try to intervene, it's between you and their money, and that's a violent situation. And this is the world I work in, like the addiction world, right? So not every patient asking you for cannabis is going to clean their guns and think of you. So discontinuation. When do we want to taper off? If there's no functional benefit, if they're impaired in the office, if their psychotic symptoms appear, if they're driving under the influence, if they have safety-sensitive work or play, and if they're diverting. So is it all a panacea and every illness in the world is going to be treated by the cannabis industry? I don't think so. Is it the devil's harvest and we should steer clear and we'll never have any health benefit? I don't think so. So I think truth lies somewhere in between, and there's going to be a lot of exciting research on all sorts of cannabinoids that will come out over the years. 100 cannabinoids. We've got a lot yet to discover and a lot of strains, and we may find certain ones with certain balances are going to help us with a lot of different diseases, but it's very early on. So I've tried to synthesize for you the known medical research, and hopefully that's of use to you and your patients. Nora Volkov's article I sometimes hand out, like the adverse health effects, so that the patients can see that if they're making a decision about whether to use or not. They have some nice tables on that article. Yeah, so that's my talk. And I guess we're having questions at the end, is that right? Do we have any time now? We good? 2 minutes? Any questions right now? I have a little thing here. You can do that. Yeah. Neuropathic pain is super hard to treat, by the way. So no matter what medicine you're using, number needs treats between 1 in 3 and 1 in 8, sometimes up to 1 in 15. So it's really hard to treat. If you worked your way through all the medications and you're down to that and they don't have any contraindications, sometimes it is a viable thing to try. And sometimes some patients get benefit from it. And some patients can't tolerate all the other drugs we give them, which also have side effects. So there's risk and benefit with everything we do. So it's a balance. It's trying to find that level of risk and benefit with patients. But just hopefully you'll be more informed to make that choice now. So a question here. Is the mic working? Mic's not working. Do you want to come up and talk into the mic?
I think I can speak loud.
Okay, it's being recorded though, so why don't you come? Yeah, just one question.
I was wondering, how do you make
here.
the requisition stand to the lab to decide whether the patient is having one or the other cannabinoid? How do you
Oh, okay, so you know
in the
what?
lab record?
There is no CBD on the, it's only THC. Yeah, we don't test for CBD.
So I don't
No,
know
you can't
if they're
test.
doing just CBD.
No. And there's, even indica strains have a tiny bit of THC in it. Would it trigger a urine drug screen if they had, let's say they did Charlotte's Web or something, I don't want to advertise any kind, but that was the kind that was used in kids for epilepsy and stuff. So, I don't know. I haven't had any patient come in with the brand name and use it and then us urine drug test them. I did have this client the other day who swore she was on a pure CBD. She showed me the bottle. It said 100% CBD, no THC, but she tested positive for THC. So, you know, and is it enough to, maybe they add a little bit to keep the patient a little bit addicted, or maybe that's just what the plant produces and we had a super sensitive test? I don't know.